Hello, everyone, and welcome to this week's COVID Insights to Action discussion group. I'm Fred Goldstein with Accountable Health, and we're so glad you joined us today. I'm joined again this week by my two compatriots or partners, as we say, in working on COVID with a number of different clients around the country, Nick van Terheyden and Dr. Luis Saldana, both physicians. So maybe a quick introduction from each of you, and then we'll get going.
Yeah, I'm Dr. Luis Saldana, an emergency physician by career, and also a former reformed CMIO, the Chief Medical Informatics Officer involved in kind of digital health and things, and glad to be here with you today.
And I'm Nick van Terheyden. I'm also an emergency room physician and a COVID investigator and deep digger into all that is COVID related and the importance of how we return to work safely.
Yeah, and my background is in population health, and I try to apply those principles to this as we look at the problems we're dealing with from the various clients we have. So this week we decided to discuss testing, and I guess the easiest way to probably start this off is to get an introduction. Obviously, there are different types of tests, so perhaps we could discuss that and then get into how universities have been using them and what they might consider on a go-forward basis. Perhaps, Nick, would you want to start that?
Sure. So cover off the sort of basics of testing. Antibody testing, which we'll put to one side for the moment, but that's the one that requires you to take blood specifically and looks for the body's response to the disease. So have I had the disease? Potentially it could inform you as to whether you've got the disease, but both of those questions remain somewhat difficult to answer based on whatever results we get, because we don't fully understand the information that comes out of that. But there is a lot of work going on around those antibodies. The other two basic tests are the molecular test that looks for the virus and specifically the messenger RNA components. And importantly, the antigen test, which is looking for those little spiky things that we've seen. Everybody, I think, is familiar with the COVID picture. Those little spiky protrusions are instigators of a response, and we can identify them in the shedding from people's bodies. Those are the basic forms of test. And under the molecular test, we talk about PCR, or polymerase chain reaction, which is the amplification system to amplify the small amounts that we find, requires laboratory involvement. And then there are some subgroups underneath that in terms of the way that we achieve this. But for the most part, testing has been done in laboratories, or has to be done in laboratories. It requires laboratory equipment, although there's some changes afoot around that. Using some clever technology that we have had in the past, but we're now applying to COVID-19.
Mm-hmm. And I know that Luis, when we first began looking at this issue back in the right pre-summer period, as these universities we're working with were thinking of coming back, they were looking through a testing strategy and weren't really sure at that time, I think, in terms of recommendations, but I believe, we recommended testing. Can you talk through sort of the reasons for that, and then what tests we sort of were looking at that were available at that time?
Yeah, and Fred, yeah, I sure can. I think a big part you touched on is what's available at that time. I think the strategies for anybody looking at testing really has to be focused on what can you execute, what can you actually get, what can you do. I think that's a big driver of what that is. And at the time that we started working with colleges and universities, the recommendation from CDC at that time was not a recommending entry testing, but that was probably partly due to maybe political reasons or whatever. I think the CDC at that time was really not giving current guidelines that really were effective. So we went ahead and recommended to our customers to do entry testing with the idea that these young folks are coming from different parts of the state, the country, the world. for that sake, and coming to a campus where they would, in some cases, be living together on campus or off campus in dorms, fraternity houses, apartments, that type of thing. And we wanted to identify and try to safely exclude those who had COVID, active COVID, or were infectious from returning to campus and ensuring that they would not infect others at that time, because we felt this could lead to a kind of a quick outbreak or quick spike in the numbers when these folks arrived on campus, and so we actually recommended entry testing. At that time, it was PCR testing, actually used an at-home company, which was effective because it allowed that to happen before they arrived on campus, and so that was really a good strategy that we worked through. But I think that was very effective in kind of narrowing that funnel of infectious cases, kind of keep those out, and we asked those folks not to come to campus if their test was positive. I think the places that did do effective testing did some form of entry testing as well. And we're going to do the same for the spring. We're going to have the same recommendation. I think you could do it with antigen testing. I think it depends on your overall strategy. What are you going to continue to do during the semester or the year as well? And much of that again is due to availability, cost. These can be quite costly. We've finally started seeing the costs of these tests start coming down. And so I think that's making testing much more available finally.
And I know that some universities essentially set up their own labs and began to try to do this or work with the Broad Institute, but others had to go find vendors. How did that work? What did we see with these companies in terms of their ability to deliver these tests in volume, get the information back in time, et cetera, from the return perspective?
I think it was widely varied. I mean, if I was to sort of pin one specific thing on probably one of the most important issues is turnaround time. The utility of a test declines almost exponentially, in my view, with the duration it takes to get the information back. So any test that takes longer than, well, let's start at 14 days, but it's probably less than that based on the quarantine restrictions, becomes useless. What's the point in testing somebody and waiting 14 days for the result if you've quarantined them? So turnaround time is essential. And the challenge with that is both the shipping. So in many instances, you've got to get it, and you've got to get it in a transport medium that meets, transportation requirements, doesn't require special handling, any of those kind of things, and also will hold or keep the sample appropriately maintained before it actually enters into the laboratory system. So that's part one. And then there's the actual laboratory processing time, which is what we've seen some of the clients do is, bring the lab locally or, partner with local labs, that distributed mechanism so that you can get a faster turnaround time.
Yeah, I think we really were able to identify some companies that could ship these tests out to individuals at their homes or wherever they were going to be before they came back, as well as supply some for the campuses on site. And then those individuals were able to take those tests, ship them back, get the turnaround fairly rapidly before they came back. And the other key piece of that was obviously the ability to exchange that information with the university so that they would then know we've had 10,000 of our students and 7,000 have tested to date. These are 3,000 we still need. These are the ones that have got it done. Everything's completely done, and track that. And I think places have gotten pretty good at that system now. And although we did identify some problems, obviously, with the U.S. Postal Service in some cases or things like that, where some of the other shippers might have been better. And as people look at it, they may want to look at that. We know that from the holidays right now, just getting mail around is difficult. So from a testing perspective, clearly something. But you mentioned something else, and perhaps, Luis, you might want to touch on this a little bit. Some of them actually were bringing groups on site to do some of that as well, and companies they identified who could come to their campuses.
Yeah, and I think Nick touched on something, you touched on it as well about the turnaround time. And one of the things that we thought was important was to in the negotiations in the contract to have a service level agreement to for them to guarantee some priority and some guarantee that turnaround time. I think that's an important consideration as folks look at testing, if they are considering that for a college or university or even a business, that you look at a service level agreement for a turnaround time to make those actionable as far as that goes. Yeah, there's many ways to solve this. Certainly, I think we've all seen in my city, we have drive up testing, so you can do drive up testing. The thing about that you got to remember is that the advantage of the at home testing is you don't need PPE. When you have any form of testing, even drive up testing, or you got to go line up to get a swab, the folks that are taking those samples have to be wearing personal protective equipment to keep them safe as well. And so I think that's a big consideration. And the same with what you talked about, getting your own lab. Those are pretty big undertakings. But I think if you can look at it financially, if those financially make sense for a college or university to bring in, it's the typical buy. Do you buy this or do you make it yourself? Do you do it yourself type of a decision? And I think that's really tends to be a very much of a business decision on what your capabilities are.
Mm-hmm. And then as you think about this, we had the pre-testing for those, and then we saw different strategies on an ongoing basis for testing during the semester. Some campuses chose not to do random screenings, others chose to do only symptomatic testing. Where should we be falling out in that? What are your thoughts around adding that either random screening in a large scale or even just sampling?
I'm going to call out Luis's point earlier, which I think is essential here. You've got to do what you're able to do, and I think that's one of the problems. I heard recently the numbers associated with the cost of testing in one particular college was just an astounding. I mean, it blew my mind how much money they had to spend. And if you don't have that money, or you can't justify that cost, you're sort of limited. In an ideal world, the visual that I have is I sort of walk around with a little paddle that says, virus free, and then it flips at some point when suddenly it's not true anymore. It all the time, and that would require some level of testing. Obviously, that's unobtainable. And there's a spectrum in between that, and we've seen all variations of that. You sort of described them. I think surveillance testing from a population standpoint, especially when you look at a population that you have some control over and have some impact on, and present themselves in your community that you can sort of influence behavior, extraordinarily important to do some level of it, and preferably as much as possible, be it 5%, something larger than that, that says we're going to try and look for those instances of people that don't present with symptoms before they've spread the disease. And, those are both asymptomatics and pre-symptomatics. And that's especially true in the younger age group, who tend to present or don't present at all with any symptoms. We have a large number of folks who went into quarantine as a result of positive testing, who ultimately never had any symptoms. Well, we never would have caught them if we hadn't tested them or found them either, one way or another.
Mm-hmm. And as you think about moving into this next semester, obviously, as you've both hammered home, it is about the resources the university has. Is it really limited, or does it make sense to not screen or test students before they come back, just because no resources?
Well, I think you have to look at the prevailing how much the disease is out there, the virus is in your community. If you have widespread community spread, disease, you really need to screen as many folks out. You want to reduce that burden. to not perpetuate the virus spreading. Nick mentioned about the pre-symptomatics and asymptomatics, and that's what makes this a unique challenge, is just that group. If we were just talking about symptomatics, it would be easy. You just test symptomatics. They can be tested probably in the community or whatever that may be available. But the challenge is identifying those that are actively spreading the disease but may not have any symptoms, and that's been responsible for much of what we see in our communities. But in the light of the amount of virus we have in our communities right now, my sense is you have to do some form of screening testing, entry testing, to really try and reduce that burden. Have those folks isolate in place. If they have a positive test, they should stay in place and not be traveling wherever they are, or have the resources to help support their their isolation and things as well. So that I would definitely say that's the case. Again, I think we're in a very different situation now in the spring than we were in the fall in terms of the availability of testing. Is much more. There's a lot more companies out there. I think the last couple of days we've seen 2 direct consumer tests happening. So maybe there's a way to leverage direct to consumer even. That's probably not the case for coming into spring. They may not be that broadly available, but I think that's where we're going. Is that we're trying to leverage those resources for rapid testing. I think we're going to see more and more rapid testing in the communities.
And I would add that while we always talk about this issue of university doing the testing themselves, and obviously those with the resources have tended to do that and paid quite a bit of money to get testing services in, there is the option of asking individuals to get a test and report that back as some way for those that maybe have less resources to be able to fund up that kind of an operation.
And the other thing that, in terms of the context of what's going on and availability of testing, the other data point that's changed dramatically from when we first had is the virus is exploding. The presence or the prevalence of this disease is so high. When you look at the risk factors or the statistical probability of somebody getting infected and coming to college, way higher in my estimation now, or potential, unless something dramatic happens in the next few weeks, and it doesn't seem that way, we're going to have very high levels of people coming from disparate parts of the country, and have a higher risk. So it's even more important at this point because the prevalence of the disease is so much higher.
Yeah, and I think along the same lines, and you kind of mentioned this earlier, Fred, it's data and analytics. I think that's something we strongly recommend, that it's not only do you have testing, but you have to track testing, and you have to track testing results. That may include tracking outside testing as well. Have a mechanism to report outside test results, so you can actually track the positivity rate in your community as well. So I think effective data and analytics and dashboards, I think, are critically important. Some places have not really invested a lot on that either. I think if you're going to spend the money on the testing, you want to have some insights. You want to create some insights so you can actually take some actions on that. And especially when you can slice and dice the data to actually identify, possible clusters. And we've done that, that you have the ability to kind of break it down to a certain apartment complex or a certain dormitory or a certain event. You got to have the data and analytics to support testing as well.
Yeah, and that's
building on that. You need to have the data on the contact tracing as well. Yeah. You can't stop at just the data of the testing, but and that proves to be one of the richer sources. If you look at any of the sort of insights that we've gathered about the disease going forward, there's significant information coming from contact tracing. Huge respect for the people that go into the detail, and the same thing occurring, same opportunity in these colleges, businesses, all of those. You can't abdicate that responsibility to the local health authorities, they seem overwhelmed and are not doing it. It becomes a local activity that requires follow-up, and people need to be doing, and then looking at the data subsequently.
And that really points to the whole point that testing is one piece of this that needs to be part of a fully integrated strategy to be able to flow that data through, to have the systems and the dashboards and people looking at it and people making your calls and analyzing it. And then beyond that, how do you then make the adjustments to your plan to try to reduce the ongoing risk going forward as you identify these individuals? So it's really fascinating. What are you seeing now as we consider the spring? Obviously, some schools have delayed some openings for a couple of weeks, given some of the numbers. Others, are looking mid-January or so, and we're seeing some variation in testing. I think, based on the numbers we've looked at and some of the reports we pulled, it looks like more universities are going to be testing than were in the past and testing more frequently. Does that make sense?
I believe so. I mean, at a minimum, testing prior to arrival seems like a core. And even take the issue of cost. I think it was Fred, you made the point. You can ask your students to test prior to arrival. I can't speak with certainty, but I think the majority of states are offering free testing. It's accessible. There is no reason that your students, your people coming back to campus can't access that. So at a minimum, that ought to be the baseline before you allow people to come in. Otherwise, they're bringing disease to your community.
What about the antigen test? There's been all this talk about, well, it's not accurate enough. It's 70%. Da, da, da. You see all this stuff flying around the media that obviously impacts all of our thoughts and some of us more than others. What's your sense on that, and how's that going to fit into the strategy in the spring, perhaps?
Well, I think the antigen tests definitely have a place in that. And I think you're going to see an increase in that as in the use of antigen testing in the spring across the country. I've already heard Dr. Fauci kind of agreeing that the way to ramp up the testing is going to be with the antigen testing. And you've seen the Binox now from Abbott has had really good numbers in terms of sensitivity and specificity. But the idea with the antigen test is you're actually trying to identify infectious individuals. So sometimes there's a disconnect between the molecular PCR test and the antigen test. And, I think that sometimes alarms folks. But a key point is that these are generally asymptomatic individuals. So it's hard to say about sensitivity and specificity because you're trying to find the presence of the virus. So it's not like the disease or that we're trying to find here. But I think the rapidity of the results, Nick talked about it, generally the PCR tests do take longer in terms of turnaround time. So these become much more actionable because you may have an immediate result with the various antigen test platforms, and you can perform them en masse. I think the earliest we saw in this was like the NBA, the National Basketball Association, was using these tests, and the idea was they're using these tests for ongoing surveillance. So even if you have some degradation in sensitivity and specificity, the fact that you're repeating in 2 or 3 days covers that, and it'll turn positive, and you'll find those individuals with still a very narrow window of infectiousness, and so it still helps you to identify infectious individuals very early.
Mm-hmm. And I think the other thing that changed just this week, in fact, is that at least one of those antigen tests is now OTC. So it's available over the counter. It's at the Illume, I think, if I'm saying that right. It's ironically comes from Australia, but the Australians can't buy it. Not sure I understand what's going on there, but okay. It means that you can go and buy your own antigen test and have it potentially in your house when you're concerned. You can run a rapid test, and to Luis's point, all tests will show a false negative if you test somebody at the wrong time. So if I'm exposed right now to the virus and I test myself, 30 seconds from now, I'm going to be negative. Doesn't matter which test I use. It's all about timing. And, his point is so essential, this repeated testing with early return of information that is actionable changes the face of the way that we deal with this.
Mm-hmm. Let's talk about maybe a little different area on this. And Luis, you sort of mentioned this last week in our conversation when I was talking about quarantine and the fact that many people don't have the resources. So, at what point do you see an antigen test that either is so inexpensive or perhaps is distributed? Is that what we need to distribute that out to the communities and cover the cost of that? Because many people, obviously, even with this over-the-counter test, aren't going to be able to afford to buy that and stick it in their house. Thoughts on that, Luis?
Yeah, and I think we've kind of touched on, I think, before in a previous conversation, but we've seen places actually do that, push out massive testing with these antigen tests, and get them out there, like Slovakia and Liverpool, England, I think, did this in the community to really drive down the level of the virus in the community. And I think we can do that. And I think you'll see that maybe after the first of the year, a real aggressive approach to nationwide testing. Right now, we're dealing with the logistics of the vaccine. Well, I think you're gonna have the same thing. The logistics of this kind of testing, they're both big challenges. I think that, and we'll have to see. But I think we are definitely going to see these tests kind of get on the big stage now for actually driving down those levels to where we can manage it. Also, for the vaccine community to be effective, you want that as well. So I think it helps us to kind of get to a lower level than, as Nick mentioned, right now we're at such a high level. All of the efforts, everything gets overwhelmed. Contact tracing, we don't get people in quarantine and isolation. There's all kinds of issues that really snowball as we move up the curve. If we move down the curve, we can really get control of this pandemic again and really start doing some of these things, and then the vaccine can really be an effective deterrent to further spread.
And other countries are great examples of different approaches, different methodologies with different resources, different use of testing, quarantine, shutdown, lockdowns. There is no perfect answer. There's always the best available option is available. Perfect almost never is.
So we've got just a couple minutes, and I know we've also kind of like to dabble in the new and cool stuff, such as CRISPR and that testing technology. A question: do you think perhaps with the vaccine coming out that maybe some of those new technologies will just hit too late? We won't potentially need them, or is this something we'll always be doing on an ongoing basis with antigen tests and stuff like that?
I'm going to say that this stuff is with us for a long period of time. COVID-19 is not the first, certainly not the last. There will be other instances, and it has woken us up to the risks and the challenges, and all of this is going to become, will be relevant. My only fear is that, the attention span, which is tied to the money and resources, diminishes too quickly and some of this withers on the vine. But pick RNA vaccines as one instance. We went under 12 months from no vaccine, not even the knowledge of the virus, to an available vaccine that is not one, but 3, for crying out loud. That's amazing. That kind of progress applied to other diseases. Wow.
Yeah, and I'll add that I don't think in science that any of this work is wasted.
Absolutely.
I think we saw with the messenger RNA work, this was done some time back on this idea of a messenger RNA vaccine, but it was now that they kind of were able to execute that. So I think any of these technologies that are coming out now that are new and innovative will be great techniques going forward in different applications. And as Nick said, I think we're going to continue to have other pandemics as well. There may be another pandemic around the corner, so we better be prepared. So I think you want to foster that sense of innovation and discovery. So I think we will all only benefit if we continue to do that.
Absolutely. And I didn't mean to imply that that was a wasted effort. That CRISPR stuff is going to do all kinds of wonders, whether in testing or other things throughout the next years and decades ahead. I know we're up on the half hour, so I'd like to thank everyone who joined us, and thank you, Nick and Luis. The next 2 weeks, on the 23rd and the 30th of December, we will not be having COVID Insights, but we will start again on January 6th, so please look to join us then, and we'll be back at it. We hope you all have a fantastic holiday season.
Thank you.
Thanks, everybody.